I am going to present the use of immature platelet fraction in daily use of our laboratory. So I am coming from the KC Prashant Path Lab, situated 60 kilometers south of Delhi. It's a small town which is having a population of 10 lakhs and in an area of 40 square kilometers. KC Prashant Path Lab was started by the inspiration of my father, Dr. Shri KC Gupta, who supported me in each of my endeavors. I have started art blood bank to support thalassemia kids and people of Palwal. Sir, IPF, we all are talking about IPF. You all know these are the portions of young immature platelets in the peripheral blood. It is a measure of reticulated platelets, platelets which contain mRNA in the peripheral blood. It helps to track the thrombopoietic activity of the bone marrow. It increases when the platelet count increases and decreases when the platelet count falls. So, there are various causes of thrombocytopenia, as all of you know. The cause may be platelet destruction by the dengue or immune system, or sequestration in the spleen, and the third is the platelet production impairment by the bone marrow due to immune process. So, reticulated platelet is the new generation hemocytometer parameter, which helps to differentiate between the peripheral and central etiology of thrombocytopenia. So, newly formed platelets are more reactive than mature platelets due to high granule content and contains the residual RNA derived from the megakaryocytes. So, the reticulated platelets extends the possibility to establish the diagnosis of thrombocytopenia, whether either it is increased platelet consumption or bone marrow failure, without doing a bone marrow examination, which is both invasive and painful procedure for the patient. So we selected 5 cases, random cases of thrombocytopenia, and studied their IPF, MPV, and platelet count. We found a good correlation between the IPF and platelet count. We did our study on the BC 900 and collected sample in K2 EDTA. CEO can find that here in all the 5 cases, the platelet count is decreasing and the IPF is increased. So we could surely tell the patient that you don't need a platelet transfusion right now. You can wait till tomorrow or so. We could avoid platelet transfusion in all the cases except that number 2, because the platelet count was so low they could not wait for more. Another case was an incidental finding in an alcoholic male, where we found a sudden fall in platelet count in routine checkup. The patient evaluation was done and vitamin B12 was found low. Vitamin B12 injections were given and there was a gradual improvement in the platelet count. So here is the series of platelet count and the IPF. You can see on 27th it is 60,000 with the IPF of 6%. Vitamin B12 therapy was given and the platelet count increased along with the IPF level. And when the IPF was maximum, within 2 days, the platelet count also was maximum, which returned back to normal after the stoppage of therapy. Fibroscan was done in this patient, which showed moderate fibrosis. Elevated liver enzymes were seen and patient was diagnosed with chronic liver disease with thrombocytopenia. So the IPF can be used to differentiate the spectrum of chronic liver disease, whether it is hepatitis or cirrhosis. We found a nice study on this use of IPF in chronic liver disease. This is a flow cytometric analysis where we can see the IPF is seen here. So my point is that platelet and IPF can be both prognostic and diagnostic marker in various clinical settings. It can be helpful in differentiating the increased platelet destruction and decreased platelet production in different conditions, and to monitor the effectiveness of treatment for thrombocytopenia, such as corticosteroid or immunosuppression therapies. We can use it when the platelet count is low in cases of ITP, DIC, TTP or myelodysplastic syndromes, or where the platelet count is normal or high. We can use it in different conditions where altered platelet function is seen, like in acute coronary syndrome, chronic uremia, or miscellaneous conditions are there like chronic liver disease, ICU patients to analyze the sepsis, and neonates and diabetes mellitus to predict the cardiovascular events. So this is a pictorial depiction, like uh, IPF was increased in all these conditions, and which can guide us regarding the uh, adverse outcome. So few of the studies with the IPF along with the diabetes mellitus and cardiovascular complications, or use of IPF in which is correlating well with the SOFA score in sepsis patients and other diseases. So my point is that we can use it in different conditions where the chemotherapy or stem cell transplantation was done. It can be used to gain insight about the platelet function. It can be used to predict the bleeding in patients with thrombocytopenia. It is a early detection of preeclampsia or HELP syndrome. It can be used to determine whether the platelet thrombocytopenia requires a platelet transfusion or not. It can again be used to evaluate the transfusion effectiveness and in sepsis and critical illnesses patients also. So IPF can be used as a non-invasive marker in place of bone marrow examination and has multiple future possibilities which need to be explored further. Thank you.